Now, what are the surgeries that are possible on parotid gland? Extracapsular excision with facial nerve preservation indicated in non-pleomorphic benign tumors, as there is less chance of recurrence. Superficial parotidectomy with preservation of facial nerve is indicated in benign tumors, especially mixed parotid tumor and lymph node metastasis inside the parotid gland. Total parotidectomy with facial nerve preservation is indicated in malignancy with no facial nerve involvement, large benign tumors, deep lobe tumors, sentinel node dissection in the deep lobe, large tumors spreading across the lobes. Continuing with the type of parotid gland surgeries, radical parotidectomy, where the gland is excised along with facial nerve. Where is the indication for this? When there is preoperative facial paralysis or circumferential involvement of the facial nerve during surgery. Nerve grafting and facial reanimation techniques can be undertaken later. Now coming to the steps of parotidectomy. Patient is given general anesthesia, head turned to the opposite side. Electrodes are placed in the area of temporal, zygomatic, buccal and marginal mandibular branch of the facial nerve for the nerve integrity monitoring during surgery. The incision is classically Blair incision. It starts in front of the tragus, goes around the lobule of the ear and goes down along the crease line anterior border of the sternomastoid muscle. Modification of a classical Blair incision is posterior to the pinna. The incision is extended onto the occipital hairline so that the scar is not visible badly. The next step is thick flap raise to expose the gland. The skin flaps could be raised on either side to expose the gland. It could be a superficial musculo-aponeurotic system wherein the platysma, the skin and the deep fascia are reflected as a single unit. It produces less cosmetic deformity and less chance of Frey syndrome. Anteriorly, facial nerve branches have to be carefully saved.